Hello everyone, it's Gail and we're going to be starting part 2 of chapter 6, and we're going to be looking at the nurse's role in administering meds safely. The first thing that we are going to notice on a medication order in the chart or a prescription that's been written, and an example of a prescription is on page 623, is that the client's full name is on the top of it. Some locales, some pharmacies may require the patient's address there. They're all going to want their date of birth, the date and the time, not today, but the real date and time. The name of the medication goes first, and with the dosage, and then how often, and then how many pills to dispense, or the number of doses that they are to have. The route of administration goes right after the dosage, and also on the prescription they're going to put the number of refills. The printed name and signature of the prescriber is great so that you can read it. Most prescriptions go ahead and put the DEA number on them, even if they're not controlled. But if they are controlled, the DEA number of the provider must be on the written prescription. Now, in a hospital setting, they're going to be writing them on doctor's orders or in the electronic medical record. The pharmacy may go ahead, if they're giving you a bottle of medicine, and put special directions on there with little stickies that say take with food, or take with a full glass of water, or avoid sunshine. I think I said already that it requires the number of refills. If they don't put refills, you just assume that there are no refills. And then the prescriber's signature. Now, at the hospital, they were requiring the prescriber's number. It's going to be different everywhere you go, but with the electronic medical record, at least now we're able to read their writing because it's typing. This is an example of a MAR that you may see at the facility where you work. It's going to give you the time, the date that it was started, and then the date that it will stop. But up here in this right hand corner, we can start looking at our rights, because it's going to have the patient's name, their medical record number, age, sex, height, and weight. And then it used to be, when we were using paper MARs, that these were changed out on the night shift, and that was one of the jobs I had. So they were changed out daily, so they're only good for one day. At the nursing home, your MAR is going to be good for the whole month. So whoever fixes their medication administration records will get them there at the end of, let's say, September 30th is falling on a Wednesday, so they'll probably get the MARs in about the 28th or 29th, and the nurses will start checking it against the old MAR to make sure nothing fell through the cracks, and then it has to go on the chart by the first of the month. And there, though, they have a binder with all the MARs, so it actually does not go on the chart until it is the month is completed and the MAR is completed, and then it's put on the chart at the nursing home setting. That's how it works. But you see that the drug name is given, the dosage, the frequency, and then the route. And on over here, they give their dailies, or this one was twice a day. Is set up at this facility for 9 a.m. and 5 p.m. And the reason that the iron is going that is because it's supposed to be with meals. But that must just be what they're set up to do with it, because at different facilities, iron is going to be like at 8 and 5 so that it doesn't upset the stomach. And then the DocuSate's twice a day also. And it says that if they're having diarrhea, you don't have to give the stool softener. The ascorbic acid or vitamin C is given twice a day, and they're just keeping it on this 9 and 1700. You just have to know where you work, what time they give. Some facilities, last nursing home I worked at, dailies were given at 8 o'clock. And like I said, if it had to be with meals, it would be given at a different time, or it might be. And then there's certain drugs like Levaquin, which is an antibiotic that is rendered ineffective with food, so they make sure that it's not given around a mealtime. So just study this SMAR. You'll have something very similar to this on your medication checkoffs. At the bottom, you put your initials, first initial, last name, DSCNS. So that's what the old paper MARS looked like. Now, with the electronic medical record, we're just checking that we gave it. With these, we would have put a line through the 9 and a line through the 17, making sure that it had been given. Okay, and you've hopefully learned in your pharmacology class about the 3 checks for medication safety, and we're going to ask you to do this during checkoffs. You're going to check your label before you pour it up, whether you pour a tablet into the lid of the container and then from there into the souffle cup, or whether you pour a liquid. You're going to check it before you pour it. And actually, for our checkoffs, you're going to be checking the label as you figure out how much to give the patient. So then after you pour, you're going to verify the label against the MAR again, and that's your second check. And then after you give it at the bedside, before you give it, you're going to check it again. So those are your 3 checks. So when you go in there to do your checkoff, you're going to look at the bottle before you start doing your calculations. That'll be your first check. And then you're going to wash your hands and do your calculations. And then you're going to pour up your medicines with us watching you, and you're checking them as you're pouring them, and then you're checking them as you're putting back in the box. So just be sure that you point out to us that you check the med at least 3 times. And we're going to be asking you what are the rights, and you need to let us know with each drug you're given that it is the right drug, dose, time, route, and then at the end we'll document. There are other rights. We're giving it for the right reason, and if your doctor has ordered Tylenol for pain and your resident has a fever, then you can't give it for fever. You have to call and get a new order. You have to be giving it for the right reason. On the other hand, if they've ordered Tylenol for fever and your patient has a headache, you can't give it for the headache. You have to call and get an order to give it for the headache. Your patient has the right to know what you're giving them, and right to ask any questions, and they have the right to refuse to take the medicine. And you don't necessarily have to call the doctor right away, but at some point they need to know that the patient is refusing the medicine, unless the order was written that you could hold it for loose stools, as was that case with the colace. So patients have rights, and nurses need to follow the 6 rights of drug administration. So, As you're going into the room and as you're doing your medication checkoffs, you're going to identify yourself and the client by looking at their armband while they state their name and date of birth. And in the hospital, we'll be scanning their armband. Don't tell your instructor that you're ready to give meds until you've got fresh water in the room and the patient sitting in the high Fowler's position and you have determined that they can swallow the meds without crushing them, because we need to have them ready to go before we go in there to get them. So when we're asking their name and date of birth, just get in the habit of saying, do you have any allergies? As you're handing the client each drug, you're going to tell them this is your digoxin. Remember, I checked your apical pulse and it was 70, so that fell within the parameters of giving this medication. It's going to strengthen the force of your heart, but you need to be sure that you're not taking it if your pulse is slow. So you need to take your pulse every day when you go home. And if the patient has any questions, they may say, yes, I've been on this drug for years, or they may say, this is a new drug, or they may say, this drug don't look right. Anytime they question that the drug doesn't look right, or they tell you that I've already gotten that drug, stop, take a time out, and investigate. Don't just say, no, you hadn't had this drug. Now, some people might be confused and they hadn't had it and they think they've had it. But you're always going to question anything they question. And on this next one, it says provide adjunct interventions. If you're given a pill, a tablet that's an antihypertensive, you're going to want to have checked their blood pressure to make sure they don't bottom out. With the dig, apical pulse, with any drug that's going to decrease respirations, you're going to want to make sure their respirations are normal. Some drugs go with food, so you can give it with ice cream. If their meds can be crushed, you're going to check on that and give them with a small amount of pudding or ice cream as possible. At the nursing home, they use sugar-free jelly, and that worked out really well for the patients that had diabetes because it was sugar-free, but it tasted fairly good to the people that didn't have diabetes. So that just worked out real well. The little jellies were on the cart, so you had them right there. So then you'll administer the drug, and after you've given it, record the administration, and then evaluate the client's response to the drug. And these electronic delivery systems, they call it MAC at Hamilton. If you give like a painkiller, it's going to come up in an hour for you to evaluate their pain scale. It's also going to come up at the time you give the pain medicine to put a rating down. So you're going to have to ask the patient to rate their pain so that you can enter it into the computer, or it won't let you give the med. And then it's going to come up to remind you to evaluate in an hour to see if the pain has lessened. Now, there are special considerations when you're giving medicines to children as well as the elderly. Your textbook talks about pediatric considerations on page 636, and then the whole chapter 8 in your ATI, Nursing Care of Children's book, is on special pediatric considerations. I will tell you that the first thing, and I didn't list it, is to enlist the help of the parents, because they know how that child takes medicine, and it is perfectly fine to hand any oral medication to the parents to give, but you need to watch them give it and make sure it's given. Now, this spoon that this child has is my very favorite implement for giving oral meds to a child, because what they spit out you can mop up. If you're using a syringe and they spit it all on their chin, you can't retrieve it. But with that little spoon thing, you can wipe it and retrieve the medicine. If you're going to have to start an IV on a child or give an IM injection to a child, the child needs to be removed from the room. And there's multiple reasons for that. One of the biggest reasons that I can think of is hearing that kid scream is very upsetting to the other patients. I remember one night when one of my kids was somewhere and the nurses were trying to start an IV on this child next door, and they tried for over 30 minutes. That child screamed for over 30 minutes, and I was fixing to knock on that door when the kid quit screaming and they gave up. I mean, I was just that close. And I was going to say, y'all got to quit torturing that kid, or you got to take it somewhere because it's tore me up, it's tore my child up. All the kids on the floor were tore up. So they need to go to a treatment room for any kind of invasive procedure, whether it be starting an IV or giving an IM injection, because they have no filter. Those children are going to scream and kick, and they need to be restrained because it hurts and you can't reason with them. I've got here briefly explain procedure. Now, and I'm telling you, you can't sit down to a 2-year-old no more than you can sit down with a patient with dementia and do good patient teaching, because they are not good receivers of your information. With a child, you're not going to stick them in the bottom. You're not going to use that dorsal gluteal because they're not walking yet. Of course, they tell us not to use it now at all, but you're not going to want to use anything but the vastus lateralis on a child because that leg muscle is bigger. Take your time getting stuff together, but don't spend a lot of time talking because they're not listening. And if you're going to give an injection or start an IV, and the child, even up to 10 or 12, may need restraining because for safety purposes, because you don't want to be sticking them somewhere you're not supposed to stick them. If a child has trouble even taking oral medicines, you could start off with a popsicle. That'll help get them in a better mood and get their mouth cold. But I just can't overemphasize enlisting the parents to help you. One thing you can say is this isn't going to take long. The more you fuss, the longer it's going to take. So let's get it over with, and then we're going to watch Pinocchio, or we're going to go do a puzzle, or I'm going to get you ice cream, or something that the child really wants to do. But I can't overemphasize not wasting your breath on trying to get cooperation, because it's just not going to happen. So we're going to look at the first route of oral medications, because this is the route that we give most medicines. And in your textbook on page 610, it talks about the different types of oral meds, and it starts off with capsule, and we usually don't call them pills anymore. We call them tablets. Liquids can go oral. Buccal, the side of the mouth. Sublingual, talked about the nitroglycerin. That's one that we give a whole lot sublingual. And enteral medicines are those that we put in like a stomach tube or a peg tube. Percutaneous enteral gastrostomy tube. So those are the oral routes. And in your skills book, it's going to show you these routes better than it does in your textbook. And let me just find in your skills book the oral medicine. It kind of follows the same as your textbook, but it just gives so much more information and nice pictures. Okay, on page 416, it shows the buccal going against the cheek and then the sublingual going under the tongue. It gives you pictures of putting medications through the enteral route, through a G tube of sorts. And NG tube, the N stands for nasogastric. And if they've got to have medicines that way for a long time, they'll go ahead and put it straight in the stomach. And that's called a PEG tube or a J tube for if it's all the way down in the jejunum. So oral medicines start on page 418, talking about giving oral medicines, and then it goes to the topical medicines. But your skills book really shows you nice pictures of eye drops and eye ointments, so be sure that you're looking at that. Now this picture on this slide is a little blurred, but it shows you 1, 2, 3, 4, 5, 1, 2, 3, 4. So there's 20 pills on this thing. Is that right? And so this last number is going to be the 20. So anytime you see a big old card of pills like this, start at the last number so that you can see how many pills are left when you're doing your count. It's usually going to be narcotics that come packaged this way. If your pill is scored, I should say tablet, but if your tablet is scored, that's the only type of pill you're supposed to cut. Now, I won't say that's the only type you will cut, but for testing purposes, you're only to cut a pill that is scored, because then that's the only way you know that you're cutting it in half. Now, if you're for home use, if you put it and you're putting it in a pill container, if you'll put the pill next to each other, then if you did get a little more than a half one day, you'd get a little less than a half the next day. But this has a razor blade that'll cut it in half. We also, especially at the nursing home, have pill crushers that we can put them in, and we'll show you those at the nursing home. If you have to pour a liquid, which you will for medication checkoffs, you're going to palm the label so it won't get syrup on it and get occluded, and you're going to pour at eye level. Now you can hold that cup and put your thumbnail on the 5 mil, 10 mil, 15 mil, whatever it is you're pouring up. But sometimes y'all shake so bad that it is better just to put it on a flat surface, because you're going to, like when we measured output last week with my clinical group, you're going to want to have that cylinder flat so that you can see the meniscus. I think that's the next slide. Yeah, that's that dip. And so this is 4 mLs. I'm thinking it's mLs. It may be teaspoons. If that's an ounce is 30, and 30 isn't divided by 4. So I don't know what that is, but anyway, it's on 4. So we're going to talk a little bit more about giving medications through an NG or a G tube. The biggest thing is to get any meds you can in the liquid form so you don't have to crush it or worry about dissolving it or clogging up your tube. So check with pharmacists for a liquid form. Check and make sure that the tablet can be crushed, that it's not time released, or if it's a capsule, that it can be pulled apart. Get it down into a fine powder. This may require dissolving it for at least 30 minutes in warm water. And if it's a capsule, then mix the contents with water only with the pharmacist's advice. And so we don't want to take an extended release capsule and take it apart and then the patient get the effect of the drug all at once rather than over time. So it's very important that when putting it through the tube that you're not going to clog up your tube. So that's why we don't administer whole or undissolved meds in the tube. We are going to assess tube placement. Both of your books talk about that, aspirating stomach contents and measuring residual volume. If they're on a continuous tube feed and you aspirate their contents and you get back 200 milliliters of tube feed, and you know you're in trouble. You know it's sticking in the stomach, and that if you put the meds, they're not going down either. So you need to check your agency policy. Some say that if it's greater than 100, that you may cut the tube feeding off for an hour and recheck. But if it's not going through peristalsis down the GI tract, in a minute it's going to start coming out the mouth. So you don't want them to vomit because they can aspirate. Also, be sure that your medication is compatible with the tube feeding that's going. You're going to cut your tube feeding off and flush before you give the medicines. But if your med says it's incompatible, and medications that I can think of that are incompatible are your anti-seizure drugs. So you sure don't want your anti-seizure drugs being rendered non-effective by the tube feeding. So you may need to cut that tube feeding off for an hour or more before you put an anti-seizure drug in it. And then flush well afterwards. Now there's pictures of removing the plunger from the syringe and letting it go in by gravity. We'll be practicing this in campus lab, and depending on if the patient's on a fluid restriction, you can flush with between 15 and 30 mils of water. But when you're given a tube feeding, it's different than flushing an NG tube. When you flush it for patency, then you make sure that you use normal saline. But if you're given medicines, you can just use water. The important thing is that the 60 milliliter syringe you use, which will have a catheter tip on it, not a lure lock, and the cylinder that you use to draw your water up in are changed daily. So you're going to use a permanent marker to put the date and time on the syringe and the cylinder and change those out daily. So to let it go in by gravity, we've removed that inner barrel. We pour the liquid and medication into the barrel and allow it to flow in by gravity. If we know from experience that it won't go in by gravity, we'll disconnect and then reassemble the syringe and push it in. And it tells you to administer each med separately and flush after each, but we don't do that. If you're asked a question, that is the ideal. But imagine you had a patient getting 6 or 7 meds at 10, and you were going to give each one separately and flush after each one. It would just take too long. But before we start the tube feeding back, we're going to flush the tube and make sure that the medicine is compatible with the tube feeding, or there again, leave the pump cut off for another hour so that the medicine has a chance to get in. If the tube is connected to suction, and that would be called a lavage or leave, when we give medicines, that's a gavage, then we're not going to hook it back up to suction and have the machine suck all our meds out and into the bucket. So we're going to leave it clamped for 20 to 30 minutes to enhance absorption. Now, in the event that your tube does become clogged, most nurses immediately go and get the Coca-Cola, and that's what I usually do too, but you're not supposed to do that. They have a pipe cleaner-like device that you can get out of GI Lab, or some floors may have it, to clean the tube and get the clog out. So given enteral feedings and enteral medications is a big deal that takes a lot of time, and I hope that you'll get to see that done at the nursing home or get to help with it at the hospital. But it takes a lot of time for your teacher to do it, and most of the time we just let you go with whatever nurse has that patient with you. Topical meds are discussed on page 611 in your text and page 419 in your skills book, and they are applied directly to the body surfaces or body cavities. Um, they are given for their local effect, but sometimes you can have a systemic effect. With these transdermal patches, we put them on thinking they're going to get in your bloodstream. With eye drops, we have to press the lacrimal duct so that you don't absorb, so the patient doesn't absorb the eye drop into their general circulation. So these are types of topicals: lotions, creams, and ointments. The same medicine can come as a lotion, as a cream, or as an ointment. The doctor has to order which type he wants. The transdermal patches we see most often are for pain or for nitroglycerin. It comes in a nitro patch. Anytime you put a patch on, before you put it on, you need to make sure there's not one on already. You take them all off, and then you prepare the skin. Your book talks about how to wash and dry, and then on the patch you put the date, time, and initials. It's very important, especially with these fentanyl pain patches, that you dispose of them in a sharps box. People that are addicts have been known to go through garbage cans and scrape the medicine off of these patches and even overdose and die. So these need to be taken off and either flushed down the toilet or put in a sharps box. We can give medicines in the eye and also in the ear. Eye drops and eardrops. Eye drops are sterile, eardrops are not, and you certainly don't want to get that messed up and put an eardrop in the eye. So check that very carefully. Nasal sprays are very common now with the allergy season. We can give vaginal preparations or rectal preparations, and these are the way to put them in. There's excuse me, pictures in your skills book, so be sure you're reading chapter 26 and studying those pictures in your skills book. If you have more than one eye drop, you need to wait 5 to 10 minutes between drops. Don't just drop them all in at once. And it also shows you how to hold the ear for an adult and for a child. For a child, it's down and back and down, and an adult, it's back and up. So remember that. It talks about respiratory inhalers. I imagine some of you may have used these in the past. And it shows you a picture and gives you the different steps of exhaling and inhaling. You can have metered dose inhalers, or respiratory can come up and give you aerosols. I think Cheryl Owens was saying she was doing aerosol nebulizations because she was coughing so bad this last week. They tell you to use a spacer because you get more of the drug, but you need to be sure these are kept clean. Now, parenteral medications are shown in your skills book, and you need to know the sites, the landmarks for your IM sites. So be sure you learn that. This first picture here shows the person getting an intradermal, and that would be like a TB skin test, and it goes right up under the epidermis, and you should see a wheal. Subcutaneous, depending on how much subacute tissue the person has. You either go in at 90 or 45 degree. And then the intermuscular is usually at a 90 degree. And we also can give a Z-track, and there's a picture and explanation of that in your book. I'm not going to talk about IVs this time. We'll wait till next semester for that. So with parenteral medication, you're going to get the equipment you need, and Karen tells me that y'all have studied syringes and needles, and you can review these in your skills book 435 through 445. In our lab, we're going to be preparing meds from vials and ampules. This is shown on page 436 in your skills. You're going to learn how to reconstitute powder with a liquid and how to mix 2 meds in 1 syringe. We're going to let you have the experience of breaking an ampule. It's always important to protect yourself and not get cut, and also to protect the patient by using a filter needle so that if any glass does get down in that amp, it'll filter it out. And this is a picture of a ampule opener, and I've never had or seen one of those. You can withdraw the medicine from an ampule this way. You do not need to put air in it, but you do need to use a filter needle. Your skills book shows this picture of putting the ampule inverted, but I'd be afraid that the liquid would come down my arm, but you're supposed to be able to do it that way. This shows you injecting air into a vial, so however much liquid you want to give the patient, you need to put that much air in so that you won't have to fight the vial to get the medicine out. That creates positive pressure in there. So, we're going to cover mixing 2 different types of insulin, and then that'll end this part, and we'll go to part 3. But the doctor's order reads, give 10 units of Humulin R with 20 units of Humulin N subcutaneous daily at 7. So your first step is going to be to locate both those vials of insulin and check their expiration date. The second step, you're going to roll those vials in your hands rather than shaking them up and down. You roll them to mix and warm them, and then always wipe the rubber tops of any vial you enter with an alcohol prep and give it a little bit of time to dry. Students forget that step in med checkoffs every year, at least one of you. So be sure to wipe the top of the vial. With insulins, the N has a protein in it, so it's going to be cloudy. It's going to be extended release. The regular, the R, is going to be clear. So rather than giving them 2 injections, we're going to mix them together. Step 4 is going to be, first off, that we're going to draw up 30 units of air, and we're going to put 20 of them in the N, being sure we don't touch the insulin. Then we're going to go over to our regular insulin and inject the other 10 units of air. And while we're in that bottle, we're going to invert it and draw our 10 units out. And a big test question is to always withdraw the regular first, or always withdraw the N last. So you've got your 10 of regular in there, so you're entering the N bottle, and you want 20 of N, so you're going to pull the syringe plunger down to the 30 mark. And the last step in giving insulin is to have another nurse check your vials and your syringe to be sure that you've got the right dose. Now the MAC requires a second nurse to scan their badge, and I've seen it and I've been tempted to do it, but I haven't done it, and that is A nurse yell, I need somebody's badge to scan this insulin with me, and here you see a badge go flying down the hall. Now you need to take the time to do the check. Insulin's very important. Insulin can kill people. So you come down there and check and be sure that the patient is getting the right medication. And this is going to end part 2, and we're going to finish up this chapter in part 3 in just a minute.